What I'll be presenting today is best practices and evidence-based data on how we manage patients with COPD, both with respect to pharmacotherapeutics and non-pharmacological treatment. Next slide, please. So here's a brief outline on diagnosis and classification. Here we're using GOLD criteria, which we should all be, if not familiar now, we should be increasingly familiar with. Pharmacological management and the evidence supporting LABA-LAMA combinations, when to use triple therapy, and when we can use azithromycin, roflumilast, theophylline, non-invasive ventilation, the role of pulmonary rehab, vaccinations, etc. And that's for non-pharmacological therapies. And I'll be focusing a little on comorbidities, because it is the comorbidities which are found in patients with COPD, which play as significant a role, in addition to the primary lung problem, in predisposing patients for admission and readmission. Next slide. So first of all, we always begin with definitions, and there's a lot in it, and we'll expand on its contents. So COPD, a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. Notice that part, airflow limitation. Theoretically, one cannot make a diagnosis of COPD unless there is evidence, spirometric evidence of airflow limitation, which I'll define in a minute. But the problem is there are patients without airflow limitation who have symptoms with consequences. So the definition probably needs revising. And is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. In that regard, we're talking about cigarette smoke. On a global basis, we're talking about biomass. So when we talk about chronic airflow limitation, we're talking about mainly two sites: small airway disease. These are airways less than 2 millimeters in diameter, and parenchymal destruction. And here we're talking about emphysema, unopposed action of proteases, and to give what we recognize both pathologically, clinically, and radiologically as emphysema. Next slide. Okay, so here's a Venn diagram, just to show you the complex interplay between asthma, emphysema, chronic bronchitis, and how would we, and where we would place somebody who has no airflow obstruction. So if you look at numbers 3, 5, 4, these are patients who have mixture of COPD, a mixture of asthma, and a mixture of chronic bronchitis. And I'll talk about how that may affect management. If you look at 8, this is somebody with asthma and also COPD and chronic bronchitis. And in that box, these are patients who have airflow obstruction within those circles. Within that box, but number 10 is somebody who has spirometric evidence of airway obstruction, but doesn't have bronchitis, emphysema, or asthma. They have cystic fibrosis. It's 6, 7, and 8. These are patients with airway diseases with reversibility. They may not just have asthma. They may have some COPD with reversibility. And then subgroups 1, 11, and 2. These are patients with chronic airway disease where there's no reversibility. And usually these are the traditionally these are patients we define as with COPD or emphysema. So what I'm trying to point out here is that there's a continuum. There are many patients who have overlap conditions of both asthma and COPD that has a bearing on treatment and risk of readmission and stability or lack of stability of the disease. Next slide. So some numbers. It's a very prevalent disorder. At least 14 million people, at least 5% of the US population. It is the 3rd or 4th leading cause of death in the United States. It's probably underdiagnosed because when you look at population-based studies, abnormal spirometry consistent with COPD affects significantly more than 14 million. And part of the problem is many patients, including 20% of patients who have severe spirometric abnormalities, are asymptomatic. So you can understand that this may be an underestimated disease, but with a high cost burden. Millions of office visits, millions of outpatient visits, and of course, as you know, many hospitalizations. I've seen figures from $50 to $80 billion being spent every year in spending, in trying to keep patients out of the hospital and treating the complications when they're in the hospital. Next slide, please. So in terms of pathogenesis, it's an inflammatory condition. And I said tobacco smoke in this country is the main cause for airway inflammation, and the pathological findings are recognized as COPD. And the immune response involves our immediate response, where we recruit neutrophils and macrophages, and an adaptive response where B and T cells, which are previously sensitized, are involved in this inflammatory reaction to the noxious irritation. But I talked a little about asthma COPD overlap, and here you have a different phenotype. You have an eosinophilic inflammation, and this is Th2 mediated. And these are the patients, when I talk about therapeutics, who may particularly benefit from inhaled corticosteroids. And these are the patients with this asthma COPD overlap will have a higher rate of readmission than patients with COPD alone. The consequence of the inflammation is elaboration of pro-inflammatory cytokines and oxidative stress. And a consequence, you have two main pathological end results: small airway narrowing, which precedes emphysema. In the small airway narrowing, you'll see peribronchial fibrosis, thickening of the submucosa, mucus cell hyperplasia and hypertrophy, and you'll see mucus in the airways. And again, emphysema, this destruction of the alveoli from unopposed action of neutrophil elastase and matrix metalloproteinases. Next slide. This is kind of a simplified diagram, but it shows a relationship between increasing inflammation and progressive COPD. But the thing to point out here is that smoking is not the whole story. Even though it's the most common cause of COPD, only 20% of smokers actually develop COPD. So there are a host of reasons why patients develop COPD. But the purpose of this diagram is to show you that the greater inflammation from the greater burden of cigarette and or biomass inhalation, more severe airway obstruction, and then you have somebody who may have an acute viral illness, which is probably more common than a bacterial precipitant or an exacerbation. Next slide. So I remember the second slide, I said COPD is part of that definition, long-winded. It requires abnormal spirometry. And by that, I mean the FEV1 FVC ratio has to be less than 70%. So we don't do spirometry if patient is asymptomatic. That may be a mistake, which I'll go into in a minute. But we do it in patients who are symptomatic or they're at risk of COPD. They have family history or they're smokers. And what do we look for? First of all, look at the volume time graph. This is one way of showing obstruction. So if you remember from your medical school days, the patient is asked to empty the lungs and then take a deep inhalation and then breathe out as quickly and as forcefully as possible. You would agree that the less obstructed you are, the more volume, look at the y-axis, you are able to exhale in 1 second, versus somebody in the red graph, bottom left, the red line, who can only exhale so much within the first second because of airway obstruction. And therefore, when you calculate the FE1 FVC, where FVC refers to the total amount of liters of air you have exhaled by about 6 seconds, you will approach unity in somebody with minimal airway narrowing because you are able to empty pretty efficiently a lot of your lung volume within the first second. In contrast, somebody with increasing airway obstruction, where it takes longer to empty your lungs, the FEV1, the amount of volume you've exhaled in 1 second, will be comparatively less, and hence the ratio fraction will be larger. And so somebody with a ratio of less than 70%, it's indicative of airway obstruction. And somebody with severe and very severe airway obstruction will have FE1 FVCs significantly lower. And if you look at the flow volume graph by convention to the right, looking at on the x-axis, by convention, I'm sorry I can't show you, but the patient takes a deep breath, and on the y-axis, the highest number, when you exhale, in the absence of any airway narrowing, there's minimal resistance, and you can empty your lungs pretty efficiently, and it'll be a straight line from the y-axis to the x-axis. But the increasingly severe airway narrowing, you'll have it's a scooping here, but you have what I call curvilinearity. It takes longer to empty your lungs because of airway narrowing. And hence another way of showing a patient that they have airway obstruction is showing them this curvilinear line indicating resistance to airway emptying. And why do we do spirometry? We can help diagnose obstruction. We can see the response to treatment or lack of response and follow the natural history of the disease. And severe FEV1 reduction and ratio is associated with risk of mortality. Next slide. So how do we classify severity of airflow? And this is, we use the GOLD criteria, where mild obstruction, the FEV1 is less than 80%, but the FEV1 FVC is less than 0.7. Moderate, where the FEV1 is between 50 and 80%. Severe FEV1 greater than 30 but less than 50%. And very severe airway limitation, it was where the FEV1 is less than 30%. Okay, now we do not use these numbers to guide us with respect to pharmacotherapy. I'll show you what numbers we use in a minute. Next slide. Okay, so COPD severity, it's expressed in a number of ways. It's based on lung function, which I've just shown you, but it includes symptom burden and exacerbation history. And I'll show you how symptom burden and exacerbation history using GOLD nomenclature helps guide pharmacotherapy. I'll show you in a minute. Note there can be a dissociation between lung function and symptom burden. You can have pretty normal lung function and be very symptomatic. Conversely, you can have very abnormal lung function and have minimal symptoms. Next slide. So first of all, how do we define symptoms and in particular shortness of breath? There are a number of metrics, a number of score sheets that we use, and I incorporate them in my chart. And I use it to follow the patient's natural history. And something as simple as this, so the MMRC score, which was validated many, many years ago, over 50 years ago, holds up and can predict future mortality. And here you see a continuum with somebody who's grade 0, and they're normal. They only get short of breath with strenuous exercise. And at the other end of the continuum is somebody who's grade 4. They're short of breath on minimal daily living activities when dressing or walking across a room in a house. Next slide. And another way of following symptoms is asking a patient to complete the CAT assessment. Remember, we use the ACT assessment for asthma. For COPD, we use the CAT. And for my colleagues in clinic, we use this template as well. We use the MMRC, it's in the note, and we use the CAT assessment. And these are 7 questions. The higher the score, if it's greater than 10, it's associated with, quote, significant symptom score, unquote. And the symptoms relate to the presence or absence of cough, phlegm, chest tightness, shortness of breath walking up a hill, daily living activities, whether affecting their sleep and the lack of energy. And again, it's a good correlation between a higher score and more severely impaired FEV1. Next slide. How do we define a COPD exacerbation? All of us intuitively understand what a COPD exacerbation is, but according to the GOLD criteria, it requires for 2 consecutive days, either 2 major criteria, increased sputum volume, purulence, and or dyspnea, or 1 major and 1 minor criteria. The minor criteria include wheezings, sore throat, nasal congestion, cough. And then depending on how you define the severity of the exacerbation determines the kind of treatment. If you have a mild exacerbation, these are patients you can treat as outpatients where you may tweak the bronchodilators. For moderate exacerbation, you would introduce steroids and an antibiotic possibly. And for severe exacerbation, these are patients who are hospitalized. In addition to steroids and antibiotics, may require non-invasive ventilation and perhaps more. Next slide. So what are the predictors, or what are the factors associated with increasing risk of exacerbation? And this is a study in the ECLIPSE study, over 2,000 patients, New England Journal of Medicine. No, I think the reference is at the bottom, which seems to be clipped a little bit, not to worry. But if you distribute the slides, the reference is on the slide at the bottom there. So if you look at this graph, which is showing what are the correlates of significant odds ratio of requiring at least 2 exacerbations in 1 year during the study. The biggest risk factor was previous exacerbations. So the truism is that if you had previous exacerbations, they predict subsequent exacerbations. So these are one of the questions you have to ask a patient when you're risk stratifying them, and particularly the time of discharge, is how we should be managing this patient's peri-discharge to try and ensure we minimize the risk of them having to be readmitted. What are the other predictors? The lower the FEV1, that makes sense, less reserve. The SGRQ score, which stands for St. George Respiratory Questionnaire, which is a long-winded, greater than 40 questions. We use it for research purposes, but the higher the score, the more impaired your quality of life. And that's a risk factor and predictor of increased exacerbation risk. So is reflux, and so is an elevated white count on your index admission. Next slide. So here's a paradigm shift, and this is a study in the New England Journal which demonstrates that you can have normal spirometry and be very symptomatic. And indeed, if you have symptoms, is there any way we could shrink the slide a little? Because we're missing some of the text there. Is it possible? That's better. Okay. Is that distracting for everybody? Whatever you prefer. Whatever. Okay. But the study showed, and it was an important study because it showed that in patients with COPD or emphysema, and they may have that on a CAT scan, they can be symptomatic and have normal spirometry. But these patients with normal spirometry, if they're symptomatic, they have an increased risk of exacerbations. So this is a dilemma. We're relying on the presence of abnormal spirometry to define COPD. But indeed, these patients may have CT evidence of COPD, but have normal spirometry, but they're symptomatic, and it has consequences, which I'll show you in the next slide. The next slide. So just bear with me here. So if you look at the middle grouping, these are patients who are study patients who are current or former smokers. If you look at the third from the left versus the fourth from the left, so the third from the left, these are patients in the middle. They have normal spirometry, but their CAT score is elevated, so they're symptomatic. And you compare them with the group to the right. These are patients who have abnormal spirometry, but minimal symptoms. And you'll notice that in the group in the middle, those who are more symptomatic, even though they have normal spirometry, there's a greater risk of requiring antibiotics over the study period, steroids, office or hospital visit, or in a severe exacerbation. So presence of symptoms, even in the absence of abnormal spirometry in somebody with COPD, patients has greater consequences than somebody with abnormal spirometry and relatively asymptomatic. So that's kind of interesting, isn't it? Next slide. Okay, so remember I mentioned that we will look at the gold established tools, A, B, C, D, and I will show in the next few slides how that will help you determine how you should prescribe for patients, both in outpatients and inpatients. So I've already showed you on the far left that we define COPD based on abnormal spirometry. The FEV1 FVC has to be less than 0.7. If you look at the middle, gold 1, 2, 3, 4, we've already been over this. You can define severity of airflow and give it a gold 1 to 4 status based on the severity of the reduction FEV1. Now focus on the two columns to the right. Okay, and this is the ABCD grid, and it's easy to forget, but also easy to remember with familiarity. So bottom left, this is somebody who has low symptom score. So actually, if you move the cursor to the right, yeah, that's it. So just underneath the A, so MMRC is low and the CAT score is low. So these are patients with minimal symptoms, okay? And we call that group A. If you move it to the right, this is somebody with more symptoms, MMRC greater than 2, CAT score greater than 10. We call that B. Again, this informs therapy, which I'll get into a minute. Look at the top left, C. This is somebody who has more exacerbations, but minimal symptoms. And then the sickest person, top right, this is D. This is somebody who is more symptomatic and has more exacerbations. Okay, next slide. And before we get to pharmacotherapy, this is just to mention that we use the ABCD classification to inform us with respect to treatment, which I'll get to in a minute. When you have a discordance between FEV1 and symptoms, it's important to look for comorbid conditions. Heart failure, for example, pulmonary hypertension. These patients may have normal spirometry, but have had very significantly shorter breath. You think, what's going on? Well, the clue to it, if you look at the title, the last word in the title, COPD. So as one of my learned colleagues pointed out, COPD should stand for comorbid pulmonary disease. And indeed, many patients with COPD have comorbid conditions, including significant cardiac disease, pulmonary hypertension, et cetera, et cetera. And it's these conditions which may be responsible for their presentation. And indeed, it's those conditions which may be responsible for a hospital admission or readmission, and yet we're calling it a COPD exacerbation. But please note, if we have time, I'll show you that data, that in only about 28%, 30% of times when somebody is admitted with, quote, a COPD readmission, it's actually from COPD. The majority of the time is from the comorbid conditions. Next slide. Differential diagnosis for COPD. When is it not COPD? Well, this is a little simplified, but I think it's worth going through. This again from the GOLD literature. So COPD classically is not early onset, it's midlife, slowly progressive, tobacco smoke, biomass exposure, asthma, different phenotypes obviously, but often in childhood, particularly allergic asthma, capricious changes in status with patients can feel well and not well. Normal PFTs do not rule out asthma, often a family history. One of the phenotypes is in middle-aged, particularly women with obesity. That's a neutrophil predominant inflammatory airway problem, difficult to treat with steroids, maybe somewhat resistant. Heart failure being the differential bronchiectasis. What's the difference? You may not have significant airway obstruction on spirometry, but they have chronic cough with significant phlegm production. And you'll see the classical evidence of bronchiectasis on a CAT scan and or chest x-ray. TB, obliterative bronchiolitis or bronchiolitis obliterans. Think about it in a younger person, a non-smoker. It can be associated, can be idiopathic, can be associated with autoimmune diseases, toxic inhalation, following pneumonia, following bone marrow or lung transplant. Diffuse panbronchiolitis, very rare in this country. You can see it in Asian population, particularly Japanese young men, non-smokers. Very difficult to treat, kind of progressive, and often just small airway disease. And you can infer the presence of it by looking at air trapping on a CAT scan and central lobular nodules. The airways, distal airways are very inflamed, and they appear as central lobular nodules. Next slide. Let's talk about pharmacological management. I think I'll, in the interest of time, since a lot of stuff to cover and a lot of the stuff you know, next slide. The different kinds of devices and different kinds of drugs, as you're familiar with. The muscarinic antagonists inhibit the M3 muscarinic receptor, and we use it particularly in patients with COPD versus asthma and in health. So let's go to the next slide. So what are the devices? Those of you who work on the front line in outpatients, as we all do, it's important to ensure that patients understand how the inhaler works, or they can use it properly. You would not be surprised, and you know this already, that at least 70%, sometimes more, of our patients do not use their inhalers properly. What is the point in getting insurance companies to provide extraordinarily expensive drugs with massive co-payments when patients don't know how to use them? So please spend time on every patient for every visit. Do not assume patients know how to use them properly. The meter-dose inhaler, right? That's the gold standard. The problem is it requires coordination, synchronization, and perhaps hand strength. And many patients, if they can get that right, they don't inhale fully. They inhale quickly, and that's it. They don't get it into their lungs. The dry powder inhaler, as you know, you have to generate a peak inspiratory force of at least 30 ml per minute. For patients with advanced COPD, they're not going to be able to inhale adequately enough to get the best benefit from the DPI. Next slide. The soft mist inhaler, it doesn't require propellant. You have to twist it to prime it. I think it's an extraordinary vehicle, piece of engineering. The spray comes out, is much easier for the patient. And the nebulizer obviously is the easiest to use, but it's the most bulky, time intensive. And but we use that as a gold standard. And if it ever has a role, it's for those patients who just cannot use inhalers properly. Next slide. Okay, so here's a slide. Let's spend a minute on this. These are the gold classification of COPD based on symptom score, based on number of exacerbations. So let's talk you through it. Somebody who's group A, minimal symptoms and minimal exacerbations, use a short-acting muscarinic antagonist and or short-acting beta agonist, and it will improve symptoms, increase FEV1, patients will feel better. Group 2, bottom right, patient who is more symptomatic but has minimal exacerbations, use a LAMA or a LABA. I will show you slides in a minute which show that LAMA is superior to a LABA for these patients, as it is for group 3, if we're going to use monotherapy. And for the group D, the patients who are most symptomatic with the increased greater number of exacerbations, we use double or triple therapy. So let me show you the evidence supporting the use of these drugs. Okay, next slide. Okay, these are for patients with group C or D, group C and D. These are patients with more exacerbations. It seems on this study in the New England Journal of Medicine that the use of a LAMA, tiotropium or Spiriva, was associated with decreasing COPD exacerbations compared to a LAMA, and it achieved statistical significance. And this was both for the upper graph, any exacerbation, and the lower graph for serious exacerbations. So when choosing monotherapy, the literature suggests that LAMA is superior to LABA. This has been duplicated in other studies. Next slide. Okay, so what about the combined use of a LABA-LAMA versus this individual constituent? So this is a study which compared placebo versus a LAMA versus a LABA versus combination. And if you look at the next slide, so this shows improvement in FEV1, which was the greatest in those who had dual LABA and LAMA, far right, the blue line. And second best were those patients who had a LAMA, glycopyrrolate. And third best was those patients who had a long-acting beta agonist. And of course, the least effective was placebo. So this study, and admittedly, it was only a 12-week study in patients with group C and D COPD. A LAMA is superior to a LABA, as the previous study I showed you in the New England Journal of Medicine, and combination together are even superior to single LABA or LAMA. Okay, next slide. Now, what about the role of steroids? Where do they have a role? And I'm going to show you some subgroup analysis, which with better precision, we can choose when to give a steroid. So this is the TORCH study from New England 2007, and it demonstrated the following. If you look to the graph to the right, it showed that patients who are on both a LABA and an inhaled corticosteroid, something like Breo or Advair, they had greater stabilization in the FEV1 over 3 years compared to inhaled steroid alone or inhaled LABA alone versus placebo. Next slide. So this is a more recent study. We're looking at, I apologize, it's quick, we're just going through a number of studies. But here we're looking at triple therapy, ICS, LABA, LAMA. And there are 2 drugs available right now that are available for our patients. Well, there's those 3 agents in one. So here we're comparing triple therapy versus dual therapy. And for the dual therapy, we're comparing ICS LABA versus LABA LAMA. And so it's triple therapy versus dual therapy of 2 different kinds over 1 year. And the patients were symptomatic, age over 40, had compromised FEV1, and had exacerbations. Or their FEV1 was better, but they had more exacerbations. Let's show you the results. So what did it show? Number 1, that exacerbations were least in those on triple therapy. So looking at exacerbations top left, and if you just look in the purple, the number of events per year, it was least in those on triple therapy, in patients with group D COPD. And patients in the middle, ICS-LABA, they fared better than patients on a combined LABA and LAMA. However, if you look at the graph to the right, there's a consequence, and you're probably familiar with this. If you incorporate inhaled corticosteroids, either as dual therapy with a LABA, so the middle column, or as triple therapy, there's a greater statistically increased risk of pneumonia versus if you give LABA and LAMA alone. Next slide. So here's some subgroup analysis. If you're concerned about risk of pneumonia, so who should you be reserving the inhaled corticosteroid for? So this is a study from Lancet, Respiratory Medicine, where they did subgroup analysis of that study I've just shown you. And essentially they divided the study population into two. Those who had normal eosinophil count and those who had higher eosinophil count. And you can see that in those who had triple therapy versus LABA-LAMA, there was significant reduction in exacerbations if your eosinophil count was over 300. And similarly, if you compared dual therapy, ICS-LABA versus LABA-LAMA, look at the far right. If your eosinophil count was significantly elevated, incorporating a steroid was associated with significant reduction in exacerbations. So what should we conclude? Triple therapy will decrease total number of exacerbations in people with group D COPD, but an increased risk of pneumonia. If your patient has eosinophilia, then you should prioritize use of triple therapy. They have the most benefit from it. And it may obviate or may put into context the increased potential risk of pneumonia. Next slide. Okay, next slide. Okay, so patient comes into the clinic, they're on double or triple therapy. How are they doing? When should we tweak things? Well, let's look at to the left, this flow diagram. If they remain short of breath in their LABA or LAMA, then consider dual therapy, adding a LAMA to a LABA or vice versa. If a patient's on a LABA and an inhaled corticosteroid, if they are at risk of pneumonia, maybe de-escalate, take them off the inhaled corticosteroid and substitute it with a LABA or LAMA. Okay. If despite LABA and LAMA or triple therapy, they remain short of breath, we'll talk about advanced therapy, but consider changing the kind of inhaler they're using. Again, look to see if they're using it properly. Maybe they'll benefit from a different kind of device. And then if you look at the exacerbations, this is somebody who's on a LABA or LAMA. One asterisk if they have eosinophilia, add an inhaled corticosteroid. If they get increased risk of pneumonia, double asterisk. Remove the inhaled corticosteroid, focus on dual therapy, LABA-LAMA. But if they're on a LABA-LAMA before and they have eosinophilia, add an inhaled corticosteroid. So if you're on triple therapy and you're still symptomatic, there may be a role for azithromycin and roflumilast, and we'll get to that. Next slide. So systemic steroids. On meta-analysis, daily systemic steroids is not a good idea. You're familiar with the short and long-term side effects, and there's an increased risk of death. It is not standard of care, but we do reserve it for patients who remain symptomatic, who seem to improve with corticosteroids, and look to see if they have an eosinophilic phenotype. They may have an asthma COPD overlap. What is the role of azithromycin? Well, we know, so I quoted a study from number 2, New England Journal of Medicine, and that's where daily azithromycin, 250 milligrams a day in patients with group C and D, COPD was associated with both improved symptoms and decreased exacerbations. But a note of caution, if they already have impaired hearing loss, I probably wouldn't give it, and check the QT. And there's a risk of bacterial resistance. And if you have somebody who may have chronic phlegm production and you're worried about bronchiectasis and MAC, particularly an elderly woman, you should not be giving azithromycin as monotherapy until you have ruled out MAC. Otherwise, you're creating opportunities for azithromycin resistance. And that's the foundational treatment for MAC. Next slide. Roflumilast is a phosphodiesterase inhibitor. Let's go to the next slide. And this is a study called the REACT study. It's from the Lancet. It was a double-blind study over 1 year. Eligible patients were older, greater than 20 pack years. They had severe airway limitation, and they had greater than 2 exacerbations a year. Patients were randomized to roflumilast or placebo, and they were continuing their maintenance therapy, which was inhaled corticosteroids and LABAs. And what were the outcomes? Next slide. In patients who received roflumilast compared to placebo or on maintenance therapy, there was a reduction in both severe events and reduction in exacerbations requiring hospital admission. And it was based on this study that roflumilast was approved. But with a caveat, the most significant risk factors for those of you who prescribe roflumilast can cause diarrhea and nausea. It can cause weight loss, and it actually has been incorporated in the pharmacotherapeutic group of medications that we give patients if you are intending the patient to lose weight, if it may benefit them, if they have concurrent sleep apnea from morbid obesity, for example. But these are problems with this drug. And they don't feel better immediately. It is not it's a trivial bronchodilator. So if you do not tell the patient they will feel better, but you tell the patient, if I'm giving it to you, it's because it is associated with decreasing severe exacerbations. The next slide. Non-pharmacological measure. Let's talk about this for the next 10 minutes. And includes the following list. Let's look at the data supporting all those key principles. Next slide. Okay, so what is clear and gold recommendations? Smoking cessation. The discussion with somebody who's an active smoker in your clinic begins and ends with smoking cessation. Smoking cessation decreases risk of lung cancer, is associated with increasing survival in patients with COPD. And we underemphasize the importance of discussing smoking cessation. We'll get to that, and you probably heard about it, hopefully ad nauseum in your residency program, but I cannot overemphasize the importance of discussions about smoking cessation. Right now, about 16–70% of Americans smoke. It's much better. During my fellowship, maybe about 24%, 25% of Americans smoke. So it's much better. And we're seeing reductions in lung cancer because of that, and lung cancer mortality. So smoking cessation for patients who are in A, B, C, and D. And physical activity, walking. That's what we do in pulmonary rehab. Walking is important. And vaccinations. Let me show you the evidence supporting vaccinations, which is why it's part of the checklist in our patients. Next slide. Before I get to, let me show you this pyramid. It's the QALY, quality associated, I'm forgetting what LY stands for. You probably know, but essentially.
Life years.
What's that?
Life years.
Life years. Excellent, Angad. Thank you. That was today's deliberate question for Angad. You got it right. So cost analysis. The cheapest thing and the most beneficial is a flu vaccination, and you can put a dollar amount. And at the top of the pyramid is telehealth, which were increasingly used. Obviously, we had to use it during COVID, but it's a way of also showing the cost of pharmacotherapy. Smoking cessation, you can put a dollar value of that. Pulmonary rehab, even though it's underutilized for reasons we'll talk about, it may be more beneficial. And then pharmacotherapy, and look how expensive it is. Now, admittedly, if I was giving this talk in England or elsewhere in the world, these drug prices would be significantly less. We are paying a lot more in this country for drugs, as you know, compared to the rest of the world. Okay, so flu vaccination, and let me show the evidence supporting flu vaccination. So it reduces COPD exacerbations. It reduces mortality in patients with COPD. For pneumococcal vaccination, the data is less robust. I'll show you a slide, next slide. So this is comparing, this shows the additive value of the pneumococcal vaccine, PV. So that's the gray line. So the gray line is a pneumococcal vaccine and influenza vaccine, where you see fewer exacerbations compared to patients who received the influenza vaccine, the darker line below. So we know from this data that pneumococcal vaccine, Q5 years plus the yearly influenza vaccine is associated with decreasing exacerbations. Next slide. Smoking cessation, for the reasons we just talked about, improves symptoms, decreased mortality, decreased exacerbations, decreased rate of decline. In an active smoker, age 35 and above, your FEV1 declines by at least 70 mil a year. When you stop smoking, it can decline, not always, to the FEV1 decline. So for all of us age over 35, the FEV1 declines by about 35 cc a year. Okay, one of the penalties for aging. And if you smoke, that rate of decline is greater. Okay, next slide. So the 5As and the 2As, and you're probably familiar with this, and we should drum this into us. For every patient, ask, advise, assess, assist, and arrange. And if you're in a hurry, AAR, ask, advise, refer, or ask, advise, and connect to smoking cessation. So within our system, Mary O'Sullivan, who you all know, runs the smoking cessation clinic. She's a great resource. You can email her, give the patient's name. She will see the patient. For another time, we can talk about the variable success rate, using different kinds of pharmacotherapy, nicotine replacement therapy, but I have a few slides on that. Next slide. So we know the second paragraph, when you, first-line therapy is nicotine replacement, gum, patch, spray. Chantix is the best. It's superior to Wellbutrin, bupropion. Noting, however, that at best, you may get a 25% plus reduction, cessation of smoking at 1 year, at best. And noting that the side effects, Chantix does not have a black box warning anymore. It did, but it had a black box warning for increased risk of suicide that is now being removed with subsequent studies. Note that in somebody who is on multiple kinds of nicotine replacement therapies, that may be as efficacious as Chantix. E-cigarettes, plus or minus, reference number 3 from the New England Journal of Medicine. In a randomized control study, e-cigarettes actually helped to decrease smoking, improve smoking cessation rates, and it was superior to nicotine replacement therapy. So look, you're all familiar with EVALI, electronic cigarette associated acute lung injury, but in pure non-adulterated e-cigarettes, it may have a role to play. Pure nicotine and whatever else they add to e-cigarettes is not benign, both locally to the airways and systemically, but it doesn't have the over 200 carcinogens that are in cigarette smoke. Next slide. These are some numbers. You can take your picture, you're probably familiar with, but patients can get advice on how to quit smoking and referrals. Next slide. Pulmonary rehab. Pulmonary rehab is defined, this is from the American Journal of Respiratory Critical Care Medicine, comprehensive intervention based on the following: exercise training, education, behavior change. I emphasize education, behavior change are just as important. And what are the benefits of pulmonary rehab? Next slide. Improved 6-minute walk test, which correlates with mortality. Improved symptom score, the St. George Respiratory Quotient. And when initiated within 3 weeks of discharge, decreasing risk of COPD exacerbations and readmission rates. So objectively, it works. Patients feel better, they walk better, decrease readmissions. Next slide. But it's underutilized, it's poorly funded, inadequate, terrible reimbursement, a disincentive for hospitals to invest in it, or insurance coverage. There are infrastructural needs. You need space. You need for exercise training, for treadmills, etc. We could talk about that another time. Staffing. Next slide. There's a role for telehealth, and COVID catalyzed that. Both telehealth pulmonary rehab for patients with long COVID or patients who've had acute respiratory failure and are improving but need pulmonary rehab. And there's data showing that telehealth-based pulmonary rehab is as efficacious in the right patient as traditional pulmonary rehab. And you use various platforms. You use, video conference, 35-minute sessions. Patients are given apparatus at home that they can use. They have to be motivated. Resistant bands, dumbbells, a bicycle or an arm bicycle with advantages. Next slide. And this is a study showing in patients who are being discharged with COPD, who receive standard of care versus a telehealth follow-up, and telehealth rehab in red on the left showed decreasing all-cause readmissions compared to standard of care post-discharge, and specifically decrease COPD readmissions in those who receive telehealth pulmonary rehab versus standard of care. So there's a role to play and increasing, and happy to answer questions in telehealth later. Next slide. Next slide. So supplemental oxygen, what are the criteria? You're probably familiar, maybe asked this on the boards. So here are some numbers. Patients hypoxic, either PaO2 less than 55 or O2 sat less than 88, or the PaO2 is higher, but greater than 55 but less than 60, but they have right heart failure on echo, pulmonary hypertension, or polycythemia. So you prescribe it, and then theoretically, we should recheck again in 2 to 3 months to see if the indication still pertains and if it's adequate. Next slide. And it works. And this is a meta-analysis from CHEST in 2010. The graph on the right incorporates 2 studies. COT stands for continuous oxygen therapy, 24 hours or as best, versus nocturnal oxygen therapy. And that landmark study many years ago showed that continuous oxygen therapy is associated with longer survival than those who have this nocturnal, for those who meet the criteria. Next slide. Now, what about, and this is controversial, and this is a recent paper in New England about 5 years ago, in patients who were prescribed oxygen purely for exercise, who desaturate. And it showed that even if the oxygen desaturation fell as low as 80%, there was no change in the endpoints, which include quality of life, lung function, acute exacerbation, but it didn't look at mortality or 6-minute walk test. So these are people with adequate resting O2 sats who on exercise desaturate. And in terms of the endpoints I've shown you, they seem to be of no benefit. Next slide. Non-invasive ventilation. This is an important study demonstrating the benefit of non-invasive ventilation in your patients who you're discharging who have hypercapnia. And here, hypercapnia was defined as a CO2 greater than 53. Or you can further presence of that if you do a VBG and let's say the PbO2 is greater than 55, 56. So you have someone particularly has severe COPD, particularly somebody who keeps coming in for readmissions for COPD. If you give them non-invasive ventilation plus home oxygen versus home oxygen alone, and then in this study it was 12 months, and they looked at readmission rates, and it was significantly reduced. Mortality was not different. If you look at the Kaplan-Meier curve, the next slide, it shows that if the outcome is admission-free survival, you'll see the benefit of both home oxygen and home non-invasive ventilation for patients with advanced COPD who recently had a COPD exacerbation. The problem is with this study, if you look at the previous slide again, these patients got a high amount of IPAP, 24 centimeters, which not all patients could tolerate. Remember, the IPAP augments your own tidal volumes, decreases work of breathing, and that's why your respiratory muscles are in better shape the next day. If you go on 2 slides. Okay, so when prescribing BiPAP and to get things right, you have to show a CO2 greater than 52, and on overnight oximetry, that even on oxygen, they're still desaturating, less than 55% after 5 minutes, or for over 5 minutes if you give them supplemental for over 2 hours, because they're not ventilating properly, and hence the role of non-invasive ventilation. Next slide. Comorbid conditions, asthma, COPD overlap. So inquire whether they have childhood asthma. Inquire if they have atopy, allergic to cats or dogs, animal dander. They may have asthma, COPD. And if their eosinophil count is high, these are patients I told you will benefit from inhaled corticosteroids. Could they have a COPD asthma overlap? Next slide. Next slide. Significant number of patients with COPD have OSA, and that has a bearing. If you look at the top right graph, if you have COPD and untreated sleep apnea, your survival is significantly less than if you have COPD alone or COPD and you're being treated with CPAP for your sleep apnea. And in terms of exacerbations, similarly, if you have COPD and sleep apnea and you don't have CPAP, you have a greater rate of exacerbations. So when we're going through our checklist and we're trying to prevent readmissions, ask them, inquire whether they have sleep apnea and get a home sleep test if necessary. And if you prescribe CPAP and they're compliant, it will decrease readmissions. Next slide. Lung cancer. Accounts for about 25% of all deaths in patients with COPD. There's a risk tool, that's reference number 2, which incorporates predicting which patients with COPD are greater risk of lung cancer. It incorporates FEV1, the presence of COPD, the presence of emphysema on a CAT scan, the presence of a low FEV1, and more. And we know that the importance of lung cancer screening. The NLST trial from New England in 2011, in those patients who met those criteria, that age greater than 30 pack year, smoking in the last 15 years, that lung cancer screening was associated with pickup of earlier lung cancer, and a 20% reduction in all-cause mortality. Next slide. Patients get depressed and are anxious who have COPD, and you cannot underestimate it. And it has effect on their quality of life, and they are frail. And certainly a low BMI is associated with increased risk of mortality in patients with COPD. There's something called the BODE index, B-O-D-E. B stands for BMI less than 19. O stands for obstructive airways disease, low FEV1, D for dyspnea, and E for exercise 6-minute walk test. As a composite, BODE is a predictor of mortality in COPD. Inquire about anxiety and depression. Next slide. And it is not inappropriate for patients who are frequent admitters, but particularly those who have severe COPD, to get palliative care involved, particularly for patients with advanced disease on home oxygen. And I quote a study there from Archives of Internal Medicine, that's the bottom part of the slide, and they compared the kind of care patients who received who had severe COPD versus the kind of care inoperable lung cancer patients had, who had less than 6 months. And the study showed that we have this bias against getting palliative care and hospice involved in advanced COPD, because in this study, those patients with COPD compared to our inoperable lung cancer cohort, their quality of life was worse. They were more depressed and anxious. They were referred less commonly to palliative care, and were more likely, unfortunately, to receive invasive therapy. So please bear that in mind. Next slide. And we have IP people who did chatter, Tim Harkin at the main hospital. There's a role for bronchoscopic management and surgical management of patients with advanced COPD using endobronchial valves, one-way valves, lung volume reduction coils, remodeling the airways, something called vapor ablation, which has been increasingly used. And the top right, patients with end-stage lung disease, we now have a lung cancer. We have a lung transplant program. And I think the first cases are going to be done in January. So if you have patients who meet the criteria, who have end-stage COPD, it's always at the end of the continuum, but we can offer that service. But if you have patients with homogeneous and or heterogeneous emphysema, they may benefit from bronchoscopic lung volume reduction. Next slide. So that's it. I have more slides, but I think we're almost out of time. So do you any questions for everybody, from anybody?
So anyone feel free to unmute yourselves or just put the question on the chat and we can read it out loud. But thank you so much, Dr. Steiger, for this great lecture.
You're welcome. So can I just give me one more minute?
Yes.
Okay, so I'm working on a system-wide committee called Standardization of COPD Management. So we're trying to make uniform in every hospital in the system where we use the same order set and the same COPD consult template. And I've kind of withdrawn it because we're tweaking it, because the COPD order set had some duplication of the basic order set. But it's almost ready for real time. And then I'll be talking to all of you about using it. Here's the hypothesis that if all of you use the COPD order set, which has enshrined in it evidence-based recommendations on how to assign medication and therapy for our patients, and also to plan peri-discharge time, I think if everybody uses it, we may decrease COPD readmissions, right? So that's a question I'm leaving with you. And so as soon as that order set is ready, I'll be selling it to you. Okay. Thank you.